Okay. Position it in inside the stent, huh?
Okay.
Inside the stent, and
I'm a bit afraid of.
you inflate at 12 atmospheres as the first ones.
Yeah. So.
And Juan, do a gentle injection.
Gentle injection, I know.
Very
we have
gentle,
not performed the pot yet.
What we call a puff.
Yeah. I was thinking of that.
Okay, this stent is well opposed.
Yeah, I see. Still, we will do the pot.
So you can deflate here. I think this was. So this is the third inflation. Third inflation has not the same diameter as the second one. Of course, there is a limit of this. After 3,
perfect.
They are joining maximum plasticity. You know. So now we have solved the problem of the distal segment. To treat the proximal segment, now we'll use the pot. So the pot, we said, would be 3.5, yeah?
It's a bit tricky. Yeah. I see. They have become
Can you hear me?
No,
yeah.
I think it will
So
be
we have
fine.
prepared 3.5. This pot PTCA balloon, especially dedicated. It is 6 millimeters long. Although we have enough space.
It's probably longer than 6. Huh? You will have probably
yes,
to do.
But anyway, we are going to do.
No, but the segment to treat.
This one is gel. So
Valerie, can you?
Yes.
Can you look at the nomogram of the balloon?
it's not bad.
Yes.
Is non-compliant? Yes. How to get 3.8 millimeter?
Well, 3.5.
3.8.
26 atmospheres is 3.0.
So that's why you are using a high pressure non-compliant balloon for a pot. We see that in literature, in meetings. This is crazy.
Yeah, this is
because this is not giving you precise diameter, the one you choose. So you choose a semi-compliant balloon, you look at the chart, and you put the pressure necessary to reach 3.8. This is what we have to do.
Just a couple of comments regarding the pot balloon. This balloon was introducing to me from Xiaoliang Chen, actually.
I know. He has no cone.
Yes, he sent me an email and said, we have a friend, we want to introduce it in Europe. And actually, in our lab, we were one of the first centers which tested this balloon, not only in Bulgaria, but the balloon is without cone. Yes, it is purely cylindrical, and it is really cylindrical.
This one, the biomarker is not far from the part of the balloon.
This exactly, yes, it is really cylindrical and should be yes, you should be very precise in position.
Don't go to 23 atmosphere. This is crazy. So what you can do here is a small puff. It's probably opposed already.
So we have to give more.
No, we have something in the diagonal. No, it's not fully opposed. So it will be for another inflation.
Okay. We are still.
Ивана, какво налягане сте? Колко ви е?
16.
16.
Дай 25 хубаво.
26 is the 3.5.
Let's leave this and let's try to go a bit more distant because it moved.
But 26 is to treat a lesion which was neglected before implantation of the stent. To deploy a stent, you need 2 atmospheres. 2 atmospheres. So this stent 0.5 atmosphere to deploy the stent. So this high pressure balloon is to treat the wall, not to deploy a stent.
Okay.
To deploy a stent, we need a semi-compliant balloon to choose the diameter.
My only concern in this case is that practically they made direct stenting and they simultaneously dilate and implant the stent. I mean that this is a direct stenting and they have to really to dilate, not only to implant the stent. This is a...
Even for pre-dilatation of a bifurcation, you still can use 2 balloons. One for the distal, one for the proximal. Of course, the distal one cannot reach the diameter of the proximal at the risk of of blocking the side branch.
But looking for how the contrast penetrates the side branches and even the diagonal, I think that probably this balloon is undersized. And
Semi-compliant?
yes, maybe 3.5, but semi-compliant now. Now.
5 semi-compliant now, because you opened the lesion.
Yes. Now it's
So I think you opened the lesion, which was a bit resisting to the first balloon. What you can do is to go back with a balloon, semi-compliant balloon,
Entangled.
at probably 14, 15, 16 atmosphere
What
normal.
I propose is to probably make the kissing, and after that anyway we have an IVUS here, and we are going to estimate what is the what we have done.
Yeah, yes, we can look at that, but my comment, because I said I will explain how to do without IVUS, my comment is that we will have malapposition of the proximal part, the pot, and the distal part will be well deployed, so no problem for the distal part.
Okay. What about making an IVUS now, and after that complete it with a non-compliant balloon as you
I can
propose?
bet that in proximal part the stent is not fully opposed, and there are at least
I think we
3
can-
zones of malapposition.
We can still use a 4 millimeters balloon, semi-compliant 4 millimeters balloon, just to. Unfortunately,
Dr. Mitov,
our
what
safety wire
would be your approach at this moment?
got entangled in the balloon, and we
I
lost.
agree with new pot with bigger balloon, semi-compliant.
Yeah, with
4.0.
4.0. The IVUS made us feel confident about doing that, and we saw that with 3.5, as if already anticipated, we are slightly undersized. So maybe
You have the force you
we need.
A question, why you are trying now to re-enter in the diagonal branch? I mean,
Yeah,
if your flow is
that's,
okay, just make an IVUS in the stand, and if it's okay, we finish the procedure. I mean, why we have to enter in the diagonal if the flow is okay, if the contrast is passing good?
Yeah, I mean, for safety, every time we go around the carina, we like to. This is the wrong one. Sorry, men can do only one thing at the same time. Women are multitask. But yeah, I mean, the wire is a bit hesitating to re-enter the vessel. But okay. So, thank you. So now we are totally safe. We didn't lost much time in this maneuver. It's a pity because the wire got entangled in the balloon, and we could not help to lose it from the safety position. But okay. Is there consensus in the panel to do a pot again with a bigger semi-compliant balloon?
Yeah, the same balloon, 4.0.
4.0.
Look at the chart, what will be the diameter.
Yeah. 4.0.
We need 3.8, so probably nominal will be enough.
Yeah. My usual approach in the cat lab is doing the pot with semi-compliant balloons, with normal balloons, because, I mean, in...
The same for me.
Okay. But the kissing with non-compliant balloons to avoid overstretching the proximal part. That's our common rule.
Okay. No? И още един манометър, да. Okay. Да.
So about the balloon, the plasticity of balloons, this is the same for non-compliant balloons. Of course,
This is
the importance
for
of
non-compliant,
plasticity is
12 millimeters.
Semi-compliant.
still exists.
Semi-compliant.
Semi-compliant is the balloon.
And between the first inflation and the nominal inflation at the diameter of the industry,
That's fine.
the difference can be 0.2 millimeters.
12 is probably better.
0.2 millimeters, this is 200 microns, and 200 microns is the definition of malapposition.
Okay. The other one was 8.
So guys, you
I don't know. That balloon,
decided to
that's not
do a
familiar
second pot.
to me. But
and then to do IVUS. Yes? Eva?
That was your proposal.
we'll find out.
Okay.
I mean, I think Eve was just guiding us. So
Yes.
we are going to do this, and probably after that I was.
So this is what...
I have a question. Who in the panel will make a kissing balloon for this?
Okay, small test.
I
Diagonal.
will not make kissing balloon because I will do a good angiography like that with a good contrast and we'll see. If the diagonal is okay, I will leave the procedure because of my age I stopped to do a lot of
Which was
things
the
in the
chart?
cath lab.
To
The
look.
chart is
8,
30 seconds again.
4.9. Okay.
So
then
during that,
let's go
this
10.
in my place in Massis,
Okay,
we are
then,
doing that since 2010, 2011.
Okay.
now it's okay.
So,
Damn it.
so of course,
let's
during
go
that
12.
time, you can discuss your vacation.
Let's go
But
12.
it's a bit longer, but it will add 2, 3, 4 minutes. to the
And
procedure.
then
Unfortunately, the contrast still penetrates behind
Now,
behind the
test
balloon.
now. Test now.
Still, yes.
So, what is
damn
it the non-compliant?
Yes.
So you see,
Semi-compliant. Semi-compliant.
And
The
we're-
14.
this is a semi-compliant.
Yeah.
14.
This one is a semi-compliant. So what you can do is increase a bit the pressure. You will increase the diameter.
Валерий,
we
какъв
already
балон
did.
взехте в крайна сметка?
Това е
14.
semi-compliant, обикновен балон,
Okay.
4 на
We
12.
achieved
Ah.
4.3.
Okay.
Is it the first inflation?
Okay,
No,
then
this is the
let's-
third
let's
one.
deflate.
The third one, say it.
Third one. I
We
guess.
increased from 9 to
Yeah.
11 to 14.
Yeah. I guess sometimes, especially in calcified lesions, we don't have to be
There is
very.
always to learn something from any
Very
case.
obsessed,
This is a very educational, by the way, because for me
wait.
this 4-0
We'll
balloon,
use again
according to
the one.
IVUS, should
I will-
resolve
I will keep
an-
both.
any
Yeah,
problem.
I can
I mean,
keep both.
with the, but
And then now,
it's
since
true
they are
that
both free,
the contrast is
it's
still
relatively easy.
penetrating.
We cannot hear you well.
the other way around.
I say that it is amazing that according to IVUS, by doing pot with this 4-0 balloon, the problem with the stent malposition should be resolved 100%. But what we saw from the contrast puffs, there was still some penetration of contrast behind the balloon. Just contrast penetrated and visualized the diagonal branch and the septum. And this is, for me, it's really unexpected, let's say so. I'm really
Yes,
surprised
but-
and I'm really
However, let me-
impatient to see how in IVUS looks this result.
There is a lot of explanation, but
Yeah,
finally
I have
we
one.
don't have any practical issues with this because we should achieve a good apposition, a good stent area by IVUS that is clearly necessary just for good immediate and long-term results. And there should be an explanation probably because there is a lot of calcium. Probably the vessel is not that circular as it needs to be. So maybe it's an important sign just to correct.
Of
but
course, it's not forbidden to inflate a fourth time, but or even a bit longer, you know.
12 is okay.
But if you do the puff and you see something, normally you're supposed to do more.
We can use the 4.0 we recently
Exactly like with IVUS, we see a malposition, you do a bigger balloon.
non-compliant. New one because with 6 friends.
Another point is that the best is the biggest enemy of the better, and probably we should not be extremely aggressive just because the next step could be just trying to improve, could achieve some beautiful complication after.
Yeah.
Of course. Do you have a stent enhancement in your cath lab?
Stent.
So this is also part of the evaluation of the result when you are so poor that you are not able to buy IVUS or CT. We're not poor in France, but these are not reimbursed. So if you are doing 2,600 PCI a year, and probably more now, it represents a big budget. So, and I'm sure, I know that from data that in Europe, intravascular imaging, it's used in 5% of procedure, no more. So Okay, during meetings, this is very interesting to show IVOS guidance and how precise it is, how we learn something we don't learn with angio. So I agree with this. But if you cannot pay to have intravascular imaging, you have to find other solutions. And one is a small puff, another one is a stent enhancement with 2 projections. You will see.
Yeah. I think the fact that we saw some contrast flowing into the side branch is, I agree with you that it's kind of unexpected because we were very precise with the sizing. However, it could make sense, as you commented, because keep in mind that we had a second wire. So this induces itself some kind of violation to the tightness that we should have. And the contrast needs just a very small space to go through.
Maybe we can discuss what to do with the diagonal, as it was suggested. I will share the position of my colleagues. This diagonal is the second one. It's not a very small one, but I don't think this is an important one. Personally, I will inflate at the ostium. I mean, I put the nose of the balloon inside the diagonal, no more. Because if you push this balloon like this, if you have a dissection, it will be longer.
Then at the side branch we will inflate just.
What is the size of the balloons for kissing?
Actually, we are going to make the most of our IVOS guidance to do a novel technique that you invented yourself, and you named POCI, which is a combination of pot and kissing.
So thank you.
POCI. So
Yes.
this was published in a Paramount journal of cardiology with a Bulgarian and Polish series of patients with good angiographic results. Angiographic and clinical
Juan made
results.
the first POCI in Germany.
And I did them. I had the privilege of doing my first POCI in Germany, and I did the second one in Ruse under your supervision. We have problems.
Yeah, you have wire twisting. So as the LED is well treated, you can move back the LED wire and cross again. So will be the solution.
Let's see. Because I think the
We discussed
but
yesterday
then-
this
then
case
I will
with
have
Juan,
more
and
friction when I try to
because
I just need
there was a
couple of- I
plan
just
what
need
to
a
do,
couple
how
of
to
millimeters.
proceed,
Yeah.
and we decided that probably he
Now-
wants
now
to.
if I put
Yes,
the other
your
one back in the other.
pot
Okay, so the
balloon
POCI,
is exactly in place.
maybe Dobrin can explain himself better than
Actually,
myself.
the point here is to use the markers of the balloons as
Exactly.
markers for
The ones.
for inflation. The side branch balloon proximal marker should be inside the stent. Exactly. Now you're in the best
exactly.
position.
So now
So
the
they are
markers.
kissing markers, the distal marker
I
of the
guess
pot
we will
balloon
inflate this to
and
6 atmospheres,
the
not
proximal
more.
marker of the side branch balloon. They are kissing. You see that they are overlapping at this moment. And this is a moment where you don't need any contrast and so on, because the balloons are exactly at the point of main vessel, side branch, and you reconstruct the anatomical. Yes, this is the problem which can exactly the sleeping. Yes, so probably Juan, you should inflate a
reposition.
little bit. Yes, a little bit back.
Yeah,
Yes,
yeah.
exactly.
Let's try.
This is another point that sometimes it is necessary
Okay,
the pot
side
balloon
branch to
marker to be
yeah, with the side branch.
distally from the
This is
side branch
not
balloon,
stable.
but this is not a problem because you
Okay,
have a
now
problem.
six,
We
the
have a
main vessel.
balloon into the side branch.
Keep the
But
six.
by,
So-
but by this technique now you have a lot of balloon in the side branch, which is unnecessary.
Okay,
So
and now,
much
the main
balloon.
vessel to 14.
You have the two markers.
We keep 6 in the side branch.
In
The main
the
vessel
marker of the
And you
pot
do
balloon.
14?
is inside the POC,
Okay.
polygon of confluence, then you can summarize two diameters there. What you have to avoid is to have a long
The main
overlap.
vessel and with the side
Why you
branch.
can put the two balloons in the POC? Because this is oval, this is not round.
No, no, okay, but in the side branch, you have about.
Yeah, you have
a lot of
but
balloons.
You are not obliged to go to high pressure there,
Yes, absolutely.
just to correct the place of the carena.
Exactly. This is the idea. Here we don't follow the equal pressures. We give a high pressure into the pot balloon and a low pressure just to reconfigure the ostium of the side branch. Not even usually I give 6 to 8 atmospheres, just to push the stand strut with a minimal risk of dissection in the side branch.
So the proximal marker of the side branch balloon is on the bifurcation.
Yes.
Okay.
It is, the marker is inside the stand.
Yes.
Only the marker is inside the stand. You see the stand?
Yes.
The marker is placed inside the stand, only marker.
Okay.
And the marker of the pot balloon is at the level
Of the pot.
of the marker of the side branch balloon, but because this is exactly the polygon of confluence,
Yes, yes.
which with angiography it's almost impossible to exactly assess, but the balloons are configuring just because these are two cylinders.
Good, interesting, yeah.
So,
And this is enough. One inflation,
I know. Without kissing.
Probably, yes.
just
Professor Vasilev, can I ask you, Dr. Allen, did you make this on a bench test?
yes. It is published in this article in Cardiology Journal.
Good.
You can see the bench.
Okay.
We made it with Orsairo stents. Actually, by the way, exactly with the Orsairo which they use. I mean, not this one. On our flexible models of the bifurcation. So the article is free, so you can read it without any problem.
Thank you.
Now we have, at the moment, 93. How much POCI?
I have the wire.
98.
I have the
Okay,
wire.
98
Okay.
patients, and we compare this cohort with our historical cohort with kissing. And we send an abstract for the EuroPCR now to present the data this year. We will see.
I bet we are.
And another information is the KISS trial was showed yesterday, I don't remember by whom, by Bernard Chevalier, my associate,
and with this one.
telling that
Distance, but not so much,
kissing,
because in the shift,
when there is no tight lesion in the ostium of the diagonal branch, of the side branch, kissing is not giving any advantage.
I see, because in the
So,
pullback, the catheter will
and
get inside.
we are just closing the review at 1 year. I am part of the CRO, so I, of course, cannot give the information, but we are just closing it. It will be represented in PCR.
We appreciate your nice
1 year
discussion.
follow-up.
So-
You have seen, okay.
This is the distal vessel.
So you will have to explain what you see because, you know, I'm not a specialist. Is it on the wall or not?
But we broke
Well, this is the distal vessel. We start to see the distal part of the stent. At this point, perfectly opposed. You see that it's almost OCT quality. So this high definition IVUS has really brought a difference. You can see the layers. Here you see the plaque burden. This stent is still well expanded, well opposed. And most importantly, the concerns when you perform the POCI is whether the distal part will be deformed. It is not deformed. And here we are already at the proximal part of the vessel. I think we have to revisit.
No, we made, he passed. By the way, this IVUS is really a perfect demonstration about the ability of this technique to restore the polygon of confluence exactly,
Yeah.
without any deformation at the carina,
Yeah, we
just
can
really
remove
to
the-
restore
the
if you
then
need
we can,
just to
maybe we
to
can
restore
try
the,
to see
the
the bifurcation.
ostium. This
I
is,
skipped
and
the bifurcation.
you skip what we have clearly demonstrated with this technique, that it
Maybe I
reduces
will-
the
I will
contrast
remove my
volume
gloves and I will
because
try
this is the pot and kissing all the manipulation at the same time, and we significantly we reduce the contrast volume, we reduce the X-ray time and the procedural time. It's true, it's 2-3 minutes, but and it is 40 seconds fluoroscopy, but 40 seconds if you calculate how many 40 seconds.
So we can conclude from this that to do a good case, you need to follow science. You need to do also tips and tricks, which are very important.
Okay. I have one question. Okay. In case we have 2 stents in bifurcation, we must make new carina. We can use POCI.
Yes.
Is enough. It's not necessary first kiss after that pot.
It's up to you if your balloon crosses the side branch direction. It's not a problem to use. My suggestion is to use 7 French.
7 French, okay.
Just
Easier.
easier.
Let me know if we. I try to see the diagonal, but
Of course, I don't have the eyes of Ivers, but what I see here is a persisting carina shift. Because you can see here, to the diagonal is coming a kind of plaque coming from distal to diagonal.
You're right.
If you have a plaque shift, this is coming from proximal because there is no plaque on the carina. So we observe exactly the opposite of this. I mean, a needle coming from proximal towards the diagonal branch. So here it's a carina shift. But as it was said yesterday, a carina shift creates an oval ostium of the side branch, as it was probably nearly around before. And it doesn't change a lot the surface. And it's very rare, as demonstrated by Bonkonku, it's very rare that it is creating a clinically significant side branch stenosis. So I think even with this, we see with IVUS, but personally I won't touch that.
Yeah, but why do we have that?
There is a very
shadow?
small dissection at the ostium, and I think that the result is excellent at this moment. The stent is perfectly opposed proximally, distally. Just, I think that any further action could only make the results worse than now. Just.
I also agree with Dobry, but can we see again the IVUS at the zone of the bifurcation, the ostium of the diagonal branch on the previous IVUS, just to stop there and to see it better?
Of the previous IVUS?
Yeah, so that you did the last IVUS.
IVUS pre-PCI?
The last one.
Ah, the last one.
Yeah, the zone of the bifurcation, exactly.
So it's difficult to see the bifurcation in the last pullback because we have a shadowing that it is shadowing exactly the takeoff of the side branch. So do we need to do a new acquisition of the? Okay.
Eva, what are you doing?
We're going to do a new pullback because there is a gap. Some of the transmitter is not working, and it is exactly at the side of the bifurcation. I mean, this sector where the bifurcation is originating. So we are trying to make another IVUS.
Okay. But anyway, my suggestion is not to manipulate anymore at the bifurcation.
Yes, the minimum stented area is around.
Not perfect, but it's very good.
Between 6 and 7 distally.
I think
with a post stent.
Absolutely, the stent is excellently opposed, totally following the anatomy of the bifurcation. Just don't touch anymore.
Maybe if you have a stent enhancement.
No, you have to go.
If it's possible to have a stent enhancement to projection, will be very interesting, I think.
Yeah. Further. Yeah, you are.
By the way, with the 2 markers of the assist IVUS, you can make a stent enhancement. Yes, there is a distal. There is a yes. Because
Yeah, very good
I'm
idea.
doing that from time
Perfect.
to time, just
Do it. Yeah, good.
to yes with this one because it has one is the proximal marker. This is a detector. This is the imaging detector, and the distal one is at the tip of the sheet of the IVUS, and you can use it like a balloon for the stent
So we
enhancement
have
if you
some
want.
muscular bridge. there.
Yes, there is a huge
Muscular bridge.
muscle bridge. Yes.
Yeah.
Yes. Now it comes a
Yes,
small
yes.
side branch
Can we have this on full screen?
in the full screen.
Screen is
So this is the
one.
distal
Ah,
part
thank you.
of the stent. See, no deformation after
Ah.
the poking. We did not. And this is our side branch, I guess. Now we could see it.
Is it malapose or
No.
No. Apparently everything is fine. And this is the second diagonal branch, proximal, still inside the stent. And now we should come to the circumflex.
Great.
This pullback is much better
Great.
for educational purposes. Some plaque in the left main, but and this is the guiding catheter. Okay.
Compliments.
You can, if you can go back to the bifurcation at the carina level just to see the
Yeah.
both vessels.
Yeah. Because this was the part. But for me, it was important to highlight with this pocket technique that you invented. We are not deformating the distal part of the stent.
No, absolutely.
Exactly. And I find it extremely
is-
smart. And probably it would deserve some position in the next Bifurcation
This is-
Club consensus.
This is a wire which is,
Yeah.
You see, because
Yeah, this is already the
wire
proximal part,
here is
so we
outside
have to go-
so you see also the
And
wire.
this is the side branch. We
Because
intend
the
to...
IVUS and wire are running in parallel, so you always see
Perfect.
the
Do we
wire.
have here, no, we have,
It's okay.
frame by frame. So, this is the bifurcation.
You can't see because you
If-
this way.
Oh, sorry. But for me it was nice, very nice.
Yeah.
So you can see at 5 o'clock, more or less, you can see the takeoff of the side branch. You can see, right?
Фари, satisfied?
Нещо
А, я.
стана 1-2 часа, стента на 1-2-3 часа, не знам нещо. Добре ли е според вас? Добре да е. Да го оставим, нищо няма да стане.
Нищо няма.
Нищо няма да стане. Окей, съгласен съм.
So this here is the guide wire.
This is
Keep
a
in mind,
catch
it's
between
not
fans.
malapose. Probably this is what if